カレッジレディオステーション MC を担当します虎ノ門病院臨床症科の三浦雄二と
富山大学泌尿器科の北村博です。
よろしくお願いし
よろし
ます。
くお願いします。
さて今回は先月2月の末にですね行われました日本臨床腫瘍学会 JSMO の話題について北村先生と2人で話をしていきたいと思います。で今回はですねロンドンからトム・パウレス先生、バートキャンサーセンターのトム・パウレス先生、昨年に引き続き来ていただいて、北村先生がなんとEV302 についてインタビューを取ってくれたので、その内容について聞いていきながら話をしていきたいなと思います。先生、ちなみに結構ジャスも忙しかったと思うんですけど、
はい。
いつの間にインタビューを。
そうなんですよね。トムも一日かなり役が当たっていて、なかなか観光にも長時間連れ出すことはできなかったんですけど、それでも限られた時間の中で、名古屋国際会議場から名古屋城までですね、タクシーで行ってきまして、そのタクシーの中で、僕とトムと2人でタクシーに乗ったので、インタビューを取ったという次第です。
なるほどですね。トムも確かに弾丸でしたよね、本当に。
そうなんです。
うん、まあ今、本当に世界中でもう引っ張りだこですよね。ネ
はい。
イチャーズ10にも選ばれましたしね、今年の、
そうなんです
昨年、
ね。
昨年ですよ
はい。
ね。う
はい。
ん。
トムは名古屋には実は一泊しかしなかったので、その
うん。
中で取れた貴重なインタビューだと思って
あ、
ます。
そうですね。トムには聞きたいことがいっぱいあると思うんですけど、インタビューの内容を聞いてみましょ
はい。それではどうぞ。Okay. So everybody wants to know the subsequent therapy after EV Pembro
Yes.
and metastatic UC.
Yes.
What regimen do you think the optimal subsequent therapy after EV Pembro?
So I don't know,
Mm-hmm.
and I don't know. I know that no one does know.
Mm-hmm.
The regime most frequently used in the EV302 study
Mm-hmm.
in patients whose cancers had progressed on EV Pembro
Mm-hmm.
was platinum-based chemotherapy by some distance. So actually, I think it was over 70% had
Yes.
platinum-based chemotherapy.
Yes.
There are other options, but I think they were infrequently used. The big debate seems to be, particularly in America, with sacituzumab govitecan,
Mm-hmm.
is that an option?
Mm-hmm.
And I think many people feel, until we've seen the results of sacituzumab govitecan in a randomised trial, it's probably premature to say it's as good as platinum-based chemotherapy in this
Yes.
setting.
Mm-hmm.
So I think most people say, sacituzumab, not yet. But some people feel that erdafitinib, because it has beaten single-agent chemotherapy in FGFR-altered patients, I think many of those people who I speak to say, yeah, well, erdafitinib in FGFR-altered tumours should be considered positively in the same way as platinum-based chemotherapy. I mean, my feeling on it is I don't think single-agent erdafitinib would beat Gem Carbo or Gem Cis first line.
Yes.
I don't think it would. And therefore, I'm not sure it's the right option. But I think it's a fair discussion.
I see. And in both subgroups, cisplatin eligible patients and cisplatin ineligible patients, even Pembro provided survival benefit.
Yes.
Yes. And do you think the subsequent therapy is different among the two groups?
Yes. So I think subsequent therapy, again, I don't know, and no one does. I think common sense dictates that subsequent therapy probably won't work quite as well as first-line therapy. But it's important to remember that the overall survival of these patients is about 35 months. It's going to end up being about 35 months, I suspect. And they're on average, they're on EV Pembro for about 12 months. So patients are alive a long time after EV Pembro. And so getting second-line therapy right does feel to be important. And I think it's possible that we can see good responses to subsequent therapies. We just don't know yet.
I see. Thank you. The next question is about the eligibility of EV-Pembro in clinical practice.
Yes.
What factors is EV-Pembro ineligible you consider?
I think it's a really good question, and I think we need to look at this whole issue very differently. Because of platinum eligibility, I think we're a bit obsessed with it in urothelial cancer. In prostate cancer, we don't talk about, or in renal cancer, we don't talk about, VEGF TKI IO eligibility. We don't create criteria around that. I think we've had to do it in kidney cancer because GemCis has got a very specific toxicity profile, and as does platinum-based chemotherapy. I think the vast majority of patients are fit for EV-Pembro. I think as with any cancer regime, if your performance status is 3, they don't tend to be included in clinical trials and don't tend to do well.
Yeah.
A contraindication, an absolute contraindication for immune therapy, active autoimmune disease on immunosuppressive agents, that would be a contraindication to Pembro. And EV, well, I think with EV, you just need, in my opinion, you need to check the glucose at the beginning to make sure they're not anemic.
I see.
Not diabetic.
Diabetic, yes.
And you need to check the hemoglobin to make sure they're not anemic. And but even if you were diabetic, that wouldn't be an absolute contraindication to me, because you would just want to monitor the blood sugars, and diabetic patients are better at controlling their blood sugars than patients who are not. So, and then an existing skin rash. Well, I don't think we know enough about that, but certainly mild psoriasis wouldn't be a contraindication for EV-Pembro.
Yes.
And in fact, it's more of a contraindication for immune therapy than EV therapy.
Do you think that psoriasis is a contraindication for all immune checkpoint inhibitor? No.
And I've treated many patients with psoriasis.
I see.
I think if you have psoriasis and you're on immune therapy,
Okay.
then you need to keep a closer eye on it, and you may get flares. And if you've got psoriasis and you're receiving immune suppressive therapy, you're receiving treatment for psoriasis, which is, then you might say, well, it's more risky.
I see.
But you know what? In the adjuvant setting, you might say you don't want to do it. Because the risk benefits in adjuvant is not as clear as in the frontline metastatic setting. But in metastatic disease, if you've got a regime with a 30% CR rate and a doubling in survival, you wouldn't want to not give it because of mild psoriasis.
I see, that makes sense. Do you imagine which kind of patients fit for a bit better for Nivo GC rather than EV-Pembro?
Yeah, so I mean, I was involved in both trials. This is my opinion, and I think most people share this opinion, is that the chemotherapy GemCis Nivo study, the benefits were a modest benefit compared to chemotherapy alone, whereas EV-Pembro was more transformative. I don't think there are any patients who are GemCis Nivo eligible who are EV-Pembro ineligible. You might say, well, what about really bad diabetes? Well, you wouldn't want to give those patients chemotherapy. They might get neutropenic sepsis. So I don't think there is a GemCis Nivo population. Now, there might be around the world. EV-Pembro may not be accessible, and GemCis Nivo, does seem like a regime which may be better than GemCis Evaluab. It's a long debate, that one. But there'll be some people say the response rate's higher, the CR rate's higher, we want to give it. I understand that discussion, but I'm not going to be queuing up to find GemCis Nivo patients. I'm happy with EV-Pembro, and if you can't have EV-Pembro, I don't think you're going to be fit enough for GemCis Nivo.
I see. Thank you. Very, very nice, informative and useful opinion and suggestions. Thank you for your great answer
Thank you very
to
much.
to my questions. Thank you. Thank you so
Thank you
much.
for asking me. I'm very grateful.
Thank you.
いやー、先生、タクシーのウィンカーの音がこれに臨場感溢れてましたね。結構あれですね、本音トークでいろいろ、まあ、先生がズバズバ
いやいやいやいや。
なんか聞きたいことをすごい聞いてくれたので、トムも本当本音トークで話してましたね。
はい。非常に貴重なインタビューだったと思ってます。
うん。先生、なんか、どのあたりが印象に残ったとかなんかありますか？
やっぱり、さすがのトム・パウルズもですね、
うん。
やっぱり難しい、トム・パウルズにとっても難し
う
い質
ん。
問なんだなっていうことをまず実感しましたね。
そうです。
当たり前ですよね。エビ
うん。
デンスがないところなので、明
うん。
確に自信を持って、これがいいんだとか、これがダメなんだっていうことは言い切れないので、
う
そこはや
ん。
っぱり個人的な考えではあるけれどもっていうような、ちょっと柔らかい言い方で、
そうですね。
え答えられたのが印象的でした。
うん。なんか、最後に先生が、GC2 ボット
はい。
どう使い分けるみたいな、質問してましたけど、
はい。
結構、まあ、やっぱり EV ペンブロ推しでしたね。
そうですね。やはり基本的にはもう、これはどの G オンコロジストもアグリーだと思いますけれども、
うん。
EV ペンブロが基本であって、どうし
うん。
ても EV いけないような人たちに、2母 GC にするか、もし
うん。
くは、トムも言ってましたけども、
うん。
まあ、GC に、ベルマブ
う
を
ん。
使うっていうのも、
うん。
まだ選択肢の一つとしては、
う
あるっていうこ
ん。
とですよね。
うん。
えー
まあ、ただあれですね、なんか、今のアベルマムメンテよりかは、まあ、むしろどっちかっていうと、GC2 母の方がまだいいのかな、みたいな、なんかそんなこともなんか言ってましたね。
そうですね、はい。
うん。あとやっぱなんか EB ペンブロがトランスフォーマティブなんだっていう、より
うん、
トランスフォーマティブなんだっていうのはなんかやっぱりちょっと印象的だなと思いました
そうです
ね。
ね、はい。
なるほど。まあ EV アンフィットに関しても、EV ペンブロアンフィットに関しても、まあそのバストマジョリティがフィットでしょうみたいな
そうなんです
そん
ね。
な感じで言ってましたしね。
え
うん、まあ、
やはり多分彼のイメージの中でも、よほどひどい皮
う
膚疾
ん、
患を持ってる人とか、よほどひどい
う
コントロール
ん、
悪い糖尿病とか、
そうですね。
えーただそういう人たちって、どんな治療もなかなか厳し
そう
い
ですね。
ことが言えるので、はい、その EV ペンブロにスペシフィックなコントラインディケーションっていうのを
うん、
見つけるというか、設定するのはなかなか難しいと思
難しいです
うんですね。
ね。うん、
はい。
うん、そうですね。まあ、あとは、まあ、ただ、今回はあんまりそこまでは話進んでなかったですけど、毒性の管理を実際我々が本当にプラクティスに出てきたときにどうやっていくのかっていう体制作りっていうか、まあ、そ
はい。
のあたりをしっかりやっていきましょうって
え
いう、そんな感じですよね。
おっしゃる通りだと思います。では、お時間になりましたので、今回はこの辺りで失礼します。次回をお楽しみに。それでは皆さん、さようなら。
さよなら。